telemedicine in South America. I worked about telehealth, telesalud guideline from Chile government, but also with Argentina and Brazil. And they started a common framework, very interesting.
Okay.
Fantastic. And dear friends, welcome everybody. We are live on Facebook from this moment onward. So we are just warming up here the room. As you see, we are live from the Zoom room, where we're going to have our global meetup starting in a few minutes, as we have already our guest keynote speakers on the room. And it's really, really great to have you all here on board. My name is Paul Nunes Diaz. This is my English name of my Portuguese name, which is Paulo Nunes de Abreu. I am the founder of the Forum Hospital of the Future, which is the umbrella organization that hosts Health Data Forum, and also the Digital Health Portugal initiative, whom I have the pleasure to have here with me, Pedro Cid Ferreira, from Cuca Tech, our partners organization on Digital Health Portugal. Pedro, if you want to show up the screen, your screen right now in a few minutes, while we arming up this place. Also, it's really a great pleasure to have here with us two guest keynotes that are going to introduce the session for the first 30 minutes. So I think that you already have them on your program. But it's Dr. Sergio Pillon is a renowned digital health star, as I say. He was featured in the World Health Organization by the WHO Europe video on digital health, and his center, the CIRM, Centro Internazionale Radiomedico, was featured as a promising beamer of what could be the future of digital health in Europe, and we hope also in India. So welcome so much, Dr. Sergio Pillon, for your presence here. We have also here with us Professor Lars Montelius, which is the Director General of the International Iberian Nanotechnology Laboratory. This is one of the leading research institutions in nanotechnology, if not to say one of the few in the world that have this capacity here, and it's really a pleasure to have you here, Professor Lars Montelius. Welcome.
Thank you.
Also, with me in this team are a number of colleagues that are going to host the session breakout. So after the 30 minutes introduction, we are going to have breakouts on the World Café. So the World Café is going to be hosted by my colleagues. So below me in the screen right now, as I see, I have Laurie Ringaert from Canada, facilitator from Canada. Laurie, welcome.
Pleased to be here, Paul.
And so Laurie will be not in breakout room 1, but in breakout room 2, is going to host the conversations on AI and tricks or tricks. Myself, I'll be also going to host breakout number 3, which is about interoperability. But last but not least, session 1, we're going to have a session room dedicated to the problems, to the UNICOM project. And Shahan Tariq and Maria Mesa are here, and they are going both to be the co-hosts. And I know that they have prepared a very interactive session, right? Shahan, do you want to advance a little bit?
Yeah, well, firstly, thank you, Paul, and it's a pleasure to be here. And you learn more about the UNICOM project at the session, so I don't want to take up time from the keynotes for now. But the session is designed to encourage discussion and collaborative brainstorming and seeing what are some of the challenges we can address together.
Fantastic. And last but not least, we have Bruno Trigo, right, from SPMS. Bruno, welcome on board. I'm sure that you must be like here by surprise, because last minute Dr. Luis Góes Pinheiro, the president of the SPMS, cannot join us today here. So Bruno was like assigned to be here. Bruno, is everything ready on your side? You're going to do a 10-minute presentation. Is this correct?
Yeah, Paul.
It's true. It's a last-minute invitation for me, but it's an honor and a pleasure to be here. And I will present a 10 minutes PowerPoint about some context about SPMES and our challenges.
Okay, so without further ado, because we are already 4 minutes ahead of time, but these 5 minutes were in the introductions, I will pass the floor to Dr. Sergio Pillon. First presentation of this session is going to start now, 10 minutes on from right now.
Thank you very much. I will start my presentation, and as I said before, this presentation was prepared for Danish embassy and was also presented in an international meeting, but I will be happy to share with you, you know, the slides are like pork, nothing goes wasted, and and this is an important lesson. So this is the title, but basically we start with the lesson from COVID. We had very bad lesson. We learned at the cost of some lives, and lives for doctor and patient. The first lesson is not always going physically to the doctor is the smartest solution. You have to avoid to go to the doctor. This seems to be the lesson, but the second lesson is a consequence. If you avoid going to the doctor, your life is in danger. Because we had, for example, in Italy, a reduction of heart attack death. Well, I can believe that we have a real reduction of heart attack. We have only a reduction of diagnosis of this kind of death. The third lesson is that Italian national healthcare system, but not only the Italian, is not a resident system. We have only an amount of resources that are just the exact number needed, or sometimes a little bit less. Overloaded hospital and overloaded health system were one of the contributing causes of very high mortality rate in Italy, but generally for COVID. The fourth lesson is on digital. Digital medicine is not so bad. We had from quote expert, a lot of bad thinking about old people and digital. We are not ready. The patient are not. They are not happy with digital. Wasn't so bad. The digital was the only solution, but sometimes was a best solution. There was an improvement, good productivity, satisfaction of workers. But the lesson is also without data you can manage, forecast, model. In Italy, you know, we had red zones, orange, yellow, and we heard too many parameters. I work with the government. You said 21. We would like to have only 5. And I said, we hope to have 100, not only 21. We need a lot of data. And this is a lesson. But we have a lesson from the past. This is Niccolò Machiavelli. Change management is a risky business. In Google, you can have the first print of this book, 1540, and let it be noted that there is no more delicate matter to take in hand, no more dangerous to conduct, nor more doubtful in its success than to set up as a leader in the introduction of changes. Our job. For he who innovates will have for his enemies all those who are well off under the existing order of things, and only lukewarm supporters in those who might be better of under the new. Obviously, because the adversaries have the laws on their side and the incredulity of mankind who never admit the merit of anything new. We are discussing about new models, all of us, until they have seen it proved by the event. And COVID gives us a good lesson. The result is that whenever the enemies of change make an attack, they do so with all the zeal of partisans, while the other defend themselves so feebly as to endanger both themselves and their cause. But Machiavelli knows quite well that the problem without a solution is nothing. So the solution is we must look whether these innovators can stand alone or whether they depend from aid upon others. In other words, whether to carry out their ends they must resort to entreaty or can prevail by force. Remember, prophets have been victorious, armed prophets have been victorious, and all unarmed prophets have been destroyed. So you need support from government. We need support from pharma companies. We need support from money. Apollo 13, they discovered the problem, so they found the solution. First of all, we have to discover that we have a problem, and the COVID-19 highlighted the presence of a problem. Before COVID-19, the problem was not really understood. In the short term, this is what happened to ambulatory visit in United States. Overall is the blue line, the absolute numbers. So you have a decrease of visits, a decrease of in-person visit. The green line is the televisit. Difference in Midwest, Northeast, South, but decrease of visit and increase of televisit, and now we have roughly a 20% of televisit. This is in percentage. 78 are in presence, but 21 are televisit. We started in Italy with the Telemedicina Subito project. We point out the differences between in-presence visit and televisit. We put the Skype symbol to explain. This was sent to doctor, to many relevant people in Italian national healthcare system. So we had the Regione Lazio as an example that started telemedicine services in the day 22 of July. So the army started the law for public and private is cheap, same amount of in-person, no extra cost. Those are lessons from, with free tools. And there is a law, you have to. You can't just say, yes, maybe, you have to. Then the manual, please read the manual. What will be the next future from the lesson? Well, this is very interesting, the survivorship bias. They try to understand where the place where to enforce the airplane, and they use the bullet holes on the wings and on the tail, and they said we have to empower the wings and the tail. But a mathematician and statistics said no. Those holes are in the airplane that survived. We have to check the other areas, the engine, the pilot, because with holes in the pilot, in the engine, they were not back. And the aero now is trying to enforce the emergency, trying to enforce the hospital in the emergency room, we have to enforce the other. You have to avoid the hospital. You have to avoid the intensive care. So the next future again. This is the digital health is a flagship initiative on WHO Europe. You explained I was, yes, a champion for this initiative, but we have to change the point of view. Those are glasses, but those are in metal, those are Murano glasses. Those are frail. You have to avoid that the frail fall, because, lesson from patient, doctor, do you know that we die because we fall? This is a lesson from a patient. You have to avoid the patient falling. It's not a problem of chronicity. So we started a project that is in Lazio region, a frailty project with Europe, with the National Research Council about AI. This is an example of the use of frailty index, same age, Mario Rossi and Gino Bianchi, but Mario Rossi with this frailty index has 28% of mortality risk in 3 years. Gino Bianchi only 8%. It's not a problem of chronicity, of frailty. So this is the future. AI, 6 fields. This is the project. We want to monitor environment. Why AI? Because we have sensor. We are integrating sensors, mobility, CO2, temperature, VOC, movement, lot of parameters integrated with AI, and control panel for environment care, mobility, biometrics, rest quality. And we will have something like this, a dashboard, easy to read, automatic alarm. So what are the lessons for the future? From chronic to frail, we have people, not disease. You know, Dr. House, I am in love with disease. I would like to avoid patient. This is not good. We have person, not disease. And the person could be rich, could be poor, could be with a university degree or only without any kind of degree. AI is not instead, AI is together with doctors. Don't be afraid as doctor about AI, because AI is here to work with us. From drug to drug and digital therapy together. We would like to enforce the adherence with digital treatment. Thank you. Here you can have my connection and everything. Thank you.
Thank you. Thank you so much. I will kindly ask everybody a round of applause or the reactions if you like these presentations, so we can have a little bit of a digital human touch here on the booth. And I think that we are receiving here the applauses for your presentation. Thank you very much. Thank you for this sharing and good thought leadership. Okay, so next speaker in the program now, Professor Lars Montelius, Director General of INL. I'm sure that is going to also to bring us a surprising presentation. I'm going to put on the spotlight now for the Facebook transmission.
Thank you so much. Thank you, Paul. So I will start by also sharing my screen here, trying to do that at least. Share, right. I guess you can see it now, right? So I will join principally what Sergio spoke about a little bit about the possibilities of use sensors and the sensorization that we are feeling or that we are experiencing around us. I will start here in this kind of a comic from an Italian magazine. I mean, 1962, long time ago. But it actually shows this kind of, if we call it social bubbles, in a very physical bubble. And this was a vision how they spoke or how they thought that now in 2022, how would society look like? And unfortunately, I mean, this was a very good, I think, a good vision for the future, because we are principally there now in an abstract form. We are asked to have the physical distance, and we are asked to not to be too close to other people. And of course, this is what you see here in these pictures. I think it was very kind of visionary. And I think the person who did that was maybe experienced a little what Sago was speaking about, when you are the prophet, when you are doing something very innovative, that people like it or don't like it. So I will start to say some few words about INL. So INL is the Intergovernmental Research Laboratory, one of the very few intergovernmental research laboratories in the world. Other intergovernmental organizations are like United Nations. The most famous intergovernmental research laboratory, I would say, is CERN, the Elementar Particle Accelerator in Switzerland. But then we also have the EMBL, which is the Microbiological Laboratory, headquartered in Heidelberg. And then we have INL. So we are principally 3 research organizations that are intergovernmental. And INL is the only one in the world focusing on nanotechnology. So it was built about 10 years ago, a little bit more than 10 years ago. And it is kind of having an international outreach. So we're trying to connect internationally, so we can have a connection to various countries. It's an intergovernmental, so we have member states as being our owners. So right now we are about 400 people there from about 40 different countries. And we are working heavily in order to make nanotechnology, or if we like, enabling technologies, to be deployed into society. So we are there in order to help society to grow, then put solutions or put possibilities there that would address societal challenges of today. So it's quite a nice activity that we are performing there, of course, but we do not only do it there. We are in other places as well. So we have representation in Scandinavia, in Israel, in Dubai, Hong Kong, Shanghai, Austin, Boston, and Brussels, and also in California nowadays. So we are kind of trying to think about and trying to help to develop things that will be very useful. About 1/3 of our activities are directly in activities with industry, where we put innovation into the market, going from, let's say, the research grade things indirectly into employment of high TRLs, so really into the market directly. We have a startup program, so we have incubated companies, of course. We are working with different kind of concepts like Scale Traverse program, which is an art and design and science program worldwide, where we have people coming, spend the time with us, and then putting up different ways to articulate science and how science can help. So if we're a little bit more focused, and we are working in 6 different areas. So one area is about the food for the future. One is in precise and personalized health tech. And this, I think, will touch quite a bit on what Sergio spoke about. Sustainable environment, advanced materials and computation, smart digital nanosystems, and clean energy. So these are the 6 kind of areas that we are focusing on. They are, of course, interlaced with each other. So in total, we have 25 research groups that are working in these areas. There is not one single group that is working in only one of these areas. So they're all working together. And this is one of the strengths of INL, is that we have people from all kinds of disciplines working together in a very strong, I would say, totally multidimensional, multi-scientific, multidisciplinary approach. So our mission is to explore interfaces between people, of course, between sciences, between engineering sciences and other sciences, but also between governments or between organizations, and of course between people. So the overall vision for INL is the 4 that you see in the bottom here: fostering a digital society, promote carbon neutrality and environmental sustainability, personalization of foods and medical nanotechnologies, and develop next generation disruptive computational technologies. So these are the 4 areas. I will not speak so much more about these 4 areas. I will go now into the more the kind of health perspectives or so. So if we think about where is health now, I mean, we heard Sergio speaking about the digital health and the possibilities within that and the telemedicine and so. If we think about where we are now, what are we facing? I mean, we're facing all these kind of, I would say, challenges: the aging population, urbanization, of course, the food supply, clean water, lifestyles, obesity, multi-sickness panorama, big data, history, experiences, etc. And then now pandemics that we're living in. And all these things, it's really limited by a cap, which is the health system, which is principally the taxpayers' abilities to pay for the cost to take care about all these things. And you have everything here is kind of interconnected with each other, right? So it's really a problem, I think, to make this. And what you need is to have a very holistic and inclusive perspective when you address the health, because health is not single. I mean, it's one part of the society, and it's a very big part, and we need to be able to do the health care in a little bit, or the health system in a little bit different perspective. One obvious thing is, of course, to bring together actors and creating this kind of enabling ecosystem that we need in order to address these, I would say, really big challenges, and also with the diversity we're having worldwide, of course. If we go to what we do at INL in our precise and personalized health tech cluster, so you see to the left, you see the health issues that we're trying to address: diagnostics, therapeutics, theranostics, drug delivery, biomarkers, and understanding. And then the engineering side to the right is where we are working. So we make sensors, really specific tailored sensors. We do a lot of microfluidics to do organ on a chip activities, etc. Fluid mechanics is very important. Electronics, obviously. NMR is very important. So we make handheld NMR instruments. Integration, photonics, microscopy. So all these things are there in order to aggregate some kind of understanding and possibilities within the health sector. So this is bringing this together, and everything is extremely interdisciplinary. So we have, as I said before, people from many different areas. So if we think about health in the digital society perspective, so if we look in the middle of this picture, it's a kind of a way to try to generate an understanding for where we are now in the digital economy or in the digital transition in society. So we have to have sensors. I mean, we need to measure something, and then when we measure that something, that needs to be communicated. It needs to be computed. I need to make some understanding. And nowadays, you use more AI and deep learning analysis activities, which you can call the smart society, if you like. And these things are then going back, because if you don't have enough data, then the AI, the deep learning will require more data. So you need to start over again and then make even more precise sensors that goes from having this kind of general perspective to be more specific. So we can put sensors in our bodies, we can put sensors in our environment, we can monitor air, water, wastewater, etc., etc. And all these things go together. So this is how the development has been. And I think the digital society has kind of, it's in 3 steps in a way. So when it became starting the digitalization, we started to we make tables out of things. And then we started to program. And then the computers did these activities for us as we program it. And now we're going into the cognitive system era, or if you like, the autonomy era, where we will have the help of the AI and the deep learning algorithms in order to help us to understand and interpret what we see, the data we are kind of aggregating and looking into. So we're going from a more automated system into a more autonomous system. And we see this in all kind of dimensions, like the self-driving cars, for instance. So we see it in the electrification, and in all other different kinds. I think this is the general trend that we have, this digitalization in society. If we go for the mega trends now in the healthcare, so the telehealth that was discussed is a very important thing. Regulation, about data privacy and how things are kind of interrelated with each other. And then that patients are more and more demanding this digital care, and they are not the blockers, so they are increasingly happy with that. But one very important aspect is, of course, who is owning the data, because if I contribute with my data, I have sensors in my body, I contribute with this data, and of course we need all the data in order to aggregate and get an understanding, but it's still my data. And I should also be part of the benefit. So I cannot just provide data for free. So we need to have a discussion about how can we secure that the data that you are providing will actually be, you will get some return on that data. One thing is, of course, you get better healthcare, if you like, but there are other perspectives as well. So the problem we have now, as I said before, is the ceiling. So we cannot spend how much money we like. I mean, there is a ceiling. And what we need to kind of change the paradigm is to kind of turn the pyramid upside down, if you like. I mean, start with the IoT, the technology stuff, and then see how that can go into the preventive care. So we do more preventive maintenance of ourselves, so more the industry 4.0 concept. And then we will be able to have much more better wellness. So it's more about securing that we're not getting sick by having more wellness, more care, rather than taking care about the guys that are sick. So by providing more healthy people in the world. So this is a kind of a paradigm. So if we just go into what we did at INL, so INL, we didn't work with virus at all, but then when the pandemic hit us, we did a lot of activities. So we really came together after this external threat and created a lot of different things, including making facial shields for the health sector close to us, but also starting to develop different activities that everything is about how can we secure the confidence in society that people can actually go back in society. So we started to not do medical diagnostics, but rather screening. And we kind of made two different things. One, you can see to the left, we call it now the INL Safe to Go, which is a breath analysis that we do not care about the biological activities of anything. We just look on the particles, the physical particles that the COVID particle is. It is a physical particle with a very well-defined size. So we measure this in breath, and that will give you, if you're a spreader or not, that will give you the confidence if you can go to the street, you can go to the shop, you can go to the theater, football match, whatever you like, you can go back to society. It's not a diagnostic tool, it's a screening tool. It's something that gives some confidence. And then you can go to the other one, which is that we work quite a lot on now, is rapid saliva detection, which is a lab test, so similar to PCR, but much more quicker, where we have a very high specificity for the time being, and we're now building it into cartridge format, so it can be used for diagnostic purposes. So these are the two different activities that we put a lot of efforts into, and we are very close now to launch them into the market, having discussions with several entities now. So with that, I just say that I hope I managed to convey some things what we do at INF. It's we are really committed. So the feeling at INF is a very passionate feeling. So we are more like an NGO in the way we are working. So really to provide value for society and saying no to everything that is just purely stupid things that has no real value for people. So thank you very much. And
thank you,
Paul.
You so much, Professor Lars Montelius, and for keeping the time within the time. I think also a round of applause that I'm seeing from the participants in the room. If you're so kind to give a little bit of human arm to those presentations. Virtual does not mean distant. Thank you very much for your feedback and on this presentation. We are live on Facebook, so all these will be recorded for you later as an MP4 file. This good content can also be shared by you. So last but not least, Bruno Trigo, in representation of Luís Góes Pinheiro, President of SPMS, SPMS is the digital arm of the Ministry of Healthcare in Portugal. Renowned by their advances in terms of digital health, Portugal has been pioneer country in many fields, electronic prescriptions and others. And I'm sure that Bruno Trigo is going to give us here a good summary of the position and outlook for 2021. Bruno, the floor is yours.
Thank you, Paul. I don't know if you are seeing my presentation. Yes?
We are, yes, we are.
Okay. I will try to put it in a small, big picture. That's fine.
It's fine now, yeah.
Okay, thank you for the introduction, Paul, and thank you for the two previous presentations. Very interesting, and it's always very interesting to see that the challenges in at so many levels are quite similar. I will try to be quick to gain some time, but as Paul said, SPMS is the technical arm for the Ministry of Health. We are not only the technical, but also the procurement arm for the Ministry of Health. So SPMS does and implements and develops, maintains the systems, but also is an important arm of the Ministry of Health in terms of purchasing some items. For example, in terms of COVID, the vaccines or the individual protection equipments, all they were bought by SPMS. There are two main other arms of the Ministry of Health: ACSS, who is the financial and ruler, and DGS, who gives the clinical guidance in the Ministry of Health. These are the three main arms of the ministry. A bit of context. So, as I said, shared services are the purchasing and logistics arm for the ministry. We have some financial services as well, and human resources, shared services of human resources, but mainly we are the information and communication systems and technologies entity of the ministry. So we give all the support the Ministry of Health needs in terms of technology and in terms of implementation, the change. And as I think the first presentation from Sergio said, I think I don't need to give detail about the costs and the pain it is to implement and to change and to do the change management of all the systems and all of the process in healthcare. In terms of installations, we are present in five different locations, but mainly in Porto and Lisbon, with our headquarters and our purchasing, logistics and public procurement. But we have also in Porto and in Maia our data center and our monitoring control center of the Portuguese NHS. Also give this note about the contact center of the Portuguese NHS, the SNS 24, that is fundamental in terms of helping citizens and contacting citizens and enlightening them and with some information. And it was a big fundamental part in managing the pandemic, the COVID pandemic, and the last few months. Our vision is to provide a good health information ecosystem to implement, but also to regulate for a more digital, integrated, and sustainable health system. As someone said before, and it's like a common phrase, we are trying to move the systems to a more the systems and the process, into a more citizen-centered way of thinking. That is not an easy process, because we have a lot of systems that are based in illness and not about the patient, or based on accounting level, on the contractualization between the hospitals and the Ministry of Health, and not about essentially the patient. To give some context or reality, we have about 54 hospitals that run our systems, 359 primary care units. These units, about 85–90% of them use our core systems. So we have two main systems in hospitals and primary care. It's the administrative system and the clinical system. I'm showing here a slide about our two main clinical systems, the S-Clinical, that is present in primary care, primary health care, but also in hospital health care. And the professionals, they spend, we did an estimate, they spend around 30 million hours a year using the clinical software in the hospital. So it's a very important platform, and we are trying to move it, or try to do the change to a more centered system, a centered citizen system, but also a centered system in a way that all the records should be seen by all the hospitals. Today, S-Clinical is a local installation. So when we try to implement centered policies, or policies that are suggested or are mandatory about the Ministry of Health, we have to implement it in all those places. Sometimes we last like 2–3 weeks to implement those changes in the system. We are trying to move it to a more centered system. Obviously, it's a big way, a big and long way, because we have to develop and to implement infrastructures that could manage all these records. As I said, we don't have only those two systems. We have like roughly 90 systems implemented in an NHS. We try to maintain them all and to develop all the functionalities needed to the professionals and to the system and to the citizen. Our goals are to support the healthcare system and care improving the population's health. In the previous presentation, we talked about the aging population and the multi-morbidity. So we have to change that, and have to change it in the technology and in the system, and how we try to change the process in the healthcare entities. We will try, and this is the main focus, to involve and improve the citizen experience. We have a big project in next year in telehealth and in telemonitoring. So we will have news in the next year about this, and try to involve the patient in his own health, and those records to be integrated in our EHR systems. We are trying, and we help to increase the efficiency of healthcare organizations, of course, and to improve quality, and to augment quality in the healthcare services and resource management. We also have our human resources system, and payroll is managed by SPMS. All the professionals are paid by our systems, and of course maximizing the working conditions of healthcare professionals, to try to help them and to give them time to look to the patient and to take care of the patient, and not to take care of the system. I will give you just two examples about what we did in the last month. We implemented our tele consultation platform, the RSA Live, for teleconsultations between user and doctor, but also between professionals. And as I said, we implemented it technology, but we are trying to change the process still. So it's a continuous implementation process. Another project I will like to talk to you. It's our tracing tracing application, not a mobile app. It's a tracing application for the professionals, public health professionals, to contact and to trace all the contacts of infected patients with COVID. And just as I said before, we also involve the patient in his own health, trying to help the patient to auto-report his symptoms. We have nowadays like 115,000 auto-reports from patients. They report those symptoms in a platform. And also we follow up the patients, and of course not obliging them to go to the primary care center, but by contacting them by phone and trying to assist them. It was a system developed in 15 days, so it was a new record. The system lasted from functional analysis, and that drawing from it was my drawing in 12th of March, and in 26th of March we did the implementation. I would just like to say that the success of software does not depend exclusively on the software. Software is an intervention to improve processes, and we don't want to lose our primary objective. So when we develop some software, we don't want to lose the intention of being digitally transformed, and it's something that it's intended and planned. It has an objective and not just implement technology by any chance. I would like to say very quickly, we will have our EL Summit in 2021. I would like to invite you all. It will be, we look forward for these events. I think I have a video, but I don't know if we have time, Paul, so I will try to fast forward.
Thank you.
So it's a technological and health summit held in Lisbon, which addresses important and everyday subjects like telehealth, digital health, artificial intelligence, robotics, e-procurement as well, public health. We did in 2017, 2019, 18, and 19. But it's always a very important event in gathering people and visions, and to share and to present some of the projects, not by SPMS, but from other stakeholders from other countries, to present and to share their experiences. And of course, we would like to invite you all. We don't have a specific date still. Some big numbers from last year, 380 speakers, 90 exhibitors, more than 50 startups, and several keynotes. So I will leave here the invitation, and would like to always be available for future clarifications. And thank you for your time, of course.
Thank you so much. Same thing, I would kindly ask for a round of applause for Bruno, so that we can have a show of a presence of everybody that was attending this presentation, Bruno. So now if you watch for gallery view, you can see the thankful welcome of everybody. And definitely Bruno has to leave. He has to go for another urgent meeting. But Bruno, if you share with me the video, I promise in the end, I show the video of eHealth Summit, because the plan we have been working to is that part of the Health Summit will be the EU-India Digital Summit. So we have a special day or 2 day for the EU-India gathering in Portugal, hopefully next year, and hopefully COVID-free and with lots of testing in the opening by the sensors from INL. That will be a good miracle. Thank you so much, dear participants. So now it's the time for the conversations to start, and this is we are going to use a World Café format. So as you probably already know about the Keynote chat environment, that I'm going to share my screen now for you to a little bit explain what is going to be next in this session. So this is we are all in this room you join in the main room, right? So we are here in this page, right? And this is, you see the participants that are in the main room. Now, what I'm going to invite you now, kindly inviting you, is to pick one of the rooms that there are 3 rooms available where you can go. You can just go select the room where you want to go. For instance, if you want to go to breakout room 1, which is the Unicom projects, then you can go to this room. And when you are here, you please select this video button here. So now what happens is you're going to be in a Zoom room just for this breakout room, right? And I kindly ask now Shahan and Maria to go there, please, and start the session, so that when participants arrive, you're already there in the room. Shahan and Maria, okay. So breakout room 2, it's another topic of discussion, which is AI in healthcare, tricks or treats. This room will be hosted by Laura Ringyard, which is here and is already in the room. So if you want to talk about AI in healthcare, tricks or treats, you go to this room, please. And finally, breakout room 3, I will be there with you. It's about the interoperability and secondary use of data, because that's also an issue we brought from the Health Data Global Hybrid Summit in October, and we want to have this also here. So remember, you will have the chance every 15 minutes. The clock will say a sound like this will bring. So you will be listening to a sound, and your hosts will tell you. Please go to, you can now change the rooms, right? So whenever you listen to this sound here, this means that you are invited to change the rooms. So you can go for another room and have another 15 minutes conversation. So we are going to split the time in 15 minutes. In order to finish on time, we are going to have 2 rounds, right? So 1 round of 15 minutes and another round. So you can choose from the 3 rooms, you can choose only 2, okay? Of course, if you are happy to be in that room, you can stay in that room all the time. It's not mandatory to change rooms. If you are happy with the conversations, if you are enjoying your conversations there, so please stay in that room. Okay, so right now, kindly invite you to make your choices, pick the rooms you like to go. And myself, I'm going to be meet you shortly in breakout room number 3 for the ones who do the health data interoperability. And we mark the clocks 15 minutes conversations, then another 15 minutes, then back to the main room for the closure. Anyone has doubts for this? Is there any questions? Please ask now. If no questions, then please let's move and let's go to the corresponding rooms. I'll see you there.